data is coming every day. So as you see, and as everybody knows, because this is in all media and everywhere, so most of cases still are in China. They started in a province in Wuhan, in the east part, and then spread out to almost all provinces in China. So the virus was to some extent starting slowly. It's now data say that it was in the beginning or mid of December, and then it continued at the beginning of January with limited spread and then spread out in China. One of the things that were discussed at that stage is the contention measures that the country was putting in place were too big, too small, too strict, whatever was discussed. Now, what is true, whatever the measures are effective or not, it continues the same picture. So most of cases are where they started and they continue to be there. This is the distribution. That's what we call the epidemic curve. So we count how many cases are distributed per day, and then are being reported, and we count the evolution. This peak that you see here, it's something that it happens from time to time, is when you call one thing in one way, what we call case definition, and up to a sudden, because there are so many cases that it doesn't worthwhile to start confirming by laboratory all the cases, you say, okay, all those that have clinical symptoms are considered cases, and we continue. So that's why this change of definition makes this big peak in this graph. But as you can see, it continues like that. It's still early to say if the cases are going down. The last report that was published by the Chinese authorities in China CDC, our brother in China, is saying that the peak was reached there and now is slowly going down, which doesn't mean that there can be a second wave. So this is the wave where we are in. It seems that it's going down, but let's see, we have to be cautious. So many times when you listen or you hear to some of us talking about that, there are many things that we don't say, but it's because of, it's better not to say things that we are not sure. It's better to say what we know so far than to speculate and give other informations. In Europe, the situation is quite contained. As you know, there are 44 cases now, so it's a limited number of cases, or 40, it continues, 45, yes. So that the figures now are evolving. All cases in Europe have a relation with Wuhan, the place where there was the initial outbreak, even though some cases have been transmitted within Europe, but this is quite easy. So in terms of better understanding, and that has been said in many different fora, even if the virus is very similar to the ones that the director mentioned before that can produce severe diseases, in terms of transmission and in terms of severity, this behaves more like the influenza in terms of number of cases, in terms of spread of blood. It's not like it is this, but it behaves more like that. This is the cases that have been reported in different EU-EA countries. And in EU-EA, we still, because we have a little number of cases, we still confirm those cases by laboratory. So it's not just symptoms or clinical, like in China, where they have thousands of cases. And here we can still afford confirming all the single cases. And this is what also the director mentioned before, what we are doing in what we call the containment phase. In the containment phase, what we are trying is to avoid that this epidemic spreads out. We contain. If the case where there are more cases, we will move to this other scenario that it's supporting hospitals, supporting primary healthcare systems, that it's more what it happens when we are in the mitigation phase. And that's something that we produce in a regular basis. So we, as ECDC, we make the risk assessment. What is the kind of risk that we can say and how we do that? So we do that considering the likelihood of something to happen and the impact if that happens. The result of that very simple formula gives us an understanding on how can we estimate the risk. And currently, this assessment based in those factors is that the infection for Europe, EU, EA, UK is low. How can we say that? So we know that the epidemic started end of December, if that was reported by January. So far, we have these 45 cases. All of them have contact with the original place, so the likelihood is low, and that makes that the formula brings us to the low. And it's based on those factors. So all cases reported have clearly established, as I mentioned, links with epidemiological links. And then the probability of transmission in the EU is considered very low. No? That you have been transmitted is very low, even less than low. However, if the impact of one or more infections is resulting in sustained transmission means that I'm infected, I transmit to one person, that person transmits to another one, and the chain continues. This is sustained transmission. Another thing is limited transmission. I contagious you, you contagious another, and stops. It doesn't continue. Even if they are local transmission, they are limited. This is the difference between limited and sustained. Then, in case there was sustained transmission, then the risk would be moderate to high, considering that the impact in people that is elderly people and with comorbidities will be very high. So will be high. So this is why we consider the risk change because of that sector of population. It's what was mentioned before again, that even if the disease is mild in general terms, for some particular groups of population, it can be more severe, and this is why we consider that. Thank you very much, and I think I pass the floor now to the Director of Folkhälsomyndigheten. Thank you.
Thank you very much for inviting me. I'm glad to be here. I'll say a few words, perhaps not so much on the Swedish situation, but more about how we work from a Swedish perspective towards Europe and the world. I'm heading the Swedish Public Health Agency. We're an agency of about 520 people, with an overarching responsibility for health, not only communicable diseases. We're doing all kinds of health issues, including alcohol, tobacco, environmental health, etc. But of course, a lot of the work we're doing is focused on communicable diseases, and in that part, the agency stems back from opened up in 1909. So we have a long tradition of this in this country. And I think I'm proud to say that we have been rather successful over the years to prevent major outbreaks in this country. Let me also roll back this discussion in time a little bit to say why do we see the European agency, the ECDC, as an interesting major partner for us. It was opened here getting towards 20 years ago now, 15 maybe, yes. But we started discussions at least more than 20 years ago. I was employed in Brussels or in Luxembourg for that time, so I've been around for many years. And the idea is to have in place an agency, a technical scientific agency helping out all the member states in European Union to assess, treat, act against communicable diseases. And that's what's happening. It's not mainly an agency that's coming to us when it's an outbreak. We have an everyday cooperation with the ECDC in all fields. HIV, vaccine preventable diseases, antimicrobial resistance. And that's the basis of the trust between member states and the agency, because you can't just jump in a situation like this unless you have a long-standing cooperation between various partners, which is, I think it's important to say. When it comes to the coronavirus, I'll refrain from showing you a lot of slides that will be more or less the same. Of course, we were also alerted when it came, and all member states started their operations more or less at the same time, of course. We have also a crisis unit working with this since the start, And we are, apart from what we're doing at home, and I'll say a few words on that, cooperating with the ECDC, of course, with other member states bilaterally, mainly in the Nordic area, where we have a lot of contacts, and primarily, of course, the WHO, especially after the WHO declared this a major event of public concern. We need to operate very closely according to the legislation, according to international health legislation with the WHO. This ECDC is, I would say, very much of a tool for us to assess the situation together in Europe. In this particular outbreak, of course, Europe is not affected in the first run, but as we heard, there are concerns. There have always been concerns when an outbreak like this appears, something that we're getting a spread. And our role is, firstly, medical intelligence, to try to find out what's going on. And that's, of course, one of the major cooperative parts with the ECDC and the WHO. How do they assess, how do we assess the situation abroad and outside Europe? The second will be surveillance, and the Swedish system is very strong, I like to say that. We have a very well-developed system for communicable diseases in this country with the local authorities in 21 counties, good staffing, good knowledge, good laboratory facilities, and coordination done at the Public Health Agency. We are seeing the local authorities twice a week, discussing the outbreak, discussing what should be done, how we see the situation, etc. We also discussing measures, information to hospitals, information to healthcare workers, information to the public, of course. And we have an FAQ running from more or less day one, and we had in the first week 700,000 downloads in our FAQ, which is a lot, of course, and a lot of people also contacting us by telephone and through other mail and other media. But the FAQ has been very successful, and of course we're trying to incorporate what the ECDC advises to do, what the WHO is doing, and our own assessment of that, because we need to realize that everything needs to be put in the context of all single member states. We cannot have a common information site there, because the legislation is different. The role of the national agencies vary a lot. I would like to say in Sweden we are very much basing our communicable disease work on trust and confidence. We try to avoid measures that will be sort of seen as overreacting on areas. And we've been very successful in doing that. Let me give an example. The vaccination programs, for example, have since 50, 60 have been voluntary in this country. We still have a 97, 98% coverage rate. In other countries with compulsory vaccination, they are down 70, 75%. So I mean, it's not only a matter about legislation force, it's much more a matter about trust and confidence. As I said, we are very much in line with the ECDC, and we also meet the ECDC. We have 2 days of scientific discussions now ending today, where all the member states are here in Stockholm to discuss with the agency how they see the problems, what are the needs, etc. And that's very fruitful. And in between, of course, we have a lot of contact with ECDC. So we are very pleased, not only that the ECDC is here in Stockholm, because we shouldn't really formally benefit from that more than other countries. To some extent we do, because it's nice to meet people and we get, but formally we have the same exchange, of course, of ideas and of information as all countries have. But of course, it's always an advantage. The disadvantage I see is they sometimes recruit my staff, and that's something we have to live with. But by and large, this is the way, and we are. I would say we, from the Swedish side, are very pleased with how things have been operating in the ECDC and on the European level. Thank you very much.
Oops, so Johan, you can actually stay, and I'll invite Andrea and Josef as well. I think, yes, that we can open up the floor for any questions or comments you might have on this. Yes, I think there's a microphone coming. Yes, there it is.
Hello, thank you for a very cognate and succinct presentation. I would like to ask a question whether categorizing COVID-19 as a respiratory disease is covering the whole picture. And the reason is that according to some papers, that somewhere between 10 and 15% of the patients present with gastrointestinal symptoms before they present with any respiratory symptoms. And this suggests that possibly there's another route of contagion. And how does people look at the question of tracking infected individuals, uses of public sanity facilities, etc.?
Should I? Okay. It's indeed true that a small percentage of infected people are presenting with gastrointestinal symptoms, diarrhea, stomachache, so forth. So it is a possibility. We don't know yet how much this really plays a role in the transmission. So that is one of the things that are currently looked at, but we have not yet good data on this. From what we see in the transmission chains that are ongoing, that is more reflecting a respiratory, a droplet a transmission. But it's very clear this is something that needs to be looked at. It was also during SARS actually a big event where it was the fecal transmission, actually the aerolization of feces in a defect sewage system in a house and so forth. But I mean, so the potential is there, but we don't know yet how big it is.
And to add that, I think also we have other diseases that are commonly called respiratory diseases, like influenza, that sometimes also present also with gastrointestinal symptoms. So when we name a disease that is respiratory transmitted, in general terms, that it's the main route of transmission according to the widespread and according to the way it is transmitted. And at the same time, in this disease, we see two patterns. So at the beginning, there was one pattern with a common source. That was the way that it's expected when it's mentioned to be the animal contact to person. And then afterwards, it continues the human-to-human transmission, where the main route, probably, it's not only, but the main route is respiratory.
And just in case you would like to know, the animal reservoir isn't detected yet. So we don't know yet from which animals it actually might have originated. It's more likely that it's bats. But I mean, it's not sure. Bats, you know, the
Fledermaus.
Yeah,
Fledermaus.
Fledermaus, yeah.
And do we have any more questions? Otherwise, I have one question in the meantime while you're... Yes?
Yes, please. Yeah, of course.
Jag undrar varför i andra länder man isolerar människorna som kommer från Kina. Man isolerar dem i 2 veckor. Och här i Sverige man gör det frivilligt om de vill isolera sig. Jag undrar varför.
So there are different possibilities how you can prevent the spread that's from one person. One is that you say, well, stay at home. Others say, well, we want these people to be in the hospitals, really isolated, and so we are the ones giving the options, saying you can do this, you can do this. Of course, it has another, how should I say, social and also, well, economical dimension, whether you isolate someone at home or in a hospital. So it is a matter of the member states, and this is why I highlighted that in the end it's the national or often even the local authorities that decide how they implement this, depending on the resources that they have available. But it has, of course, like for you, also given rise to questions in other people. And this has been recognized by the health authorities of the countries. So as one of the outcomes in last week's Health Council, in the Council conclusions that were published, it was very clearly said that countries should strive to have a more aligned approach to how for instance, contact persons are treated.
I'd like to comment on that as well. It's not entirely true that it differs very much. I mean, if you look at the situation, in the situation where people have been contained or are put in quarantine, it's mainly those people evacuated at a later stage that in some countries were put in quarantine. The other people coming into a lot of member states before that event, also having been in the same area, they were not put in quarantine. I mean, the risk... I would regard this more of a political issue than really a communicable disease issue. For example, the German situation is very interesting because where they had a real outbreak in Munich, in Bavaria, they've not contained people more than home containment as we've been doing in Sweden. But the people flown in under sort of from the evacuation, they were put in quarantine. Mm-hmm. So I mean, I would guess it's more of a show-off sometimes. Really, we are very convinced that the system of voluntary containment, a system of trust, people are well informed, etc., is the way forward. It's very unlikely that you get people to come to the health sector with symptoms coming from China if they know that what will happen to me and my family is we're going to put in 2 weeks of containment regardless of what's happening, rather than getting advice, taking responsibility. That's the way we are working, at least in this part of Europe, and I think it has been successful, and we try to stick to that. Quarantine is something they should use in very special cases, but there are high risk, dangerous diseases, and that they are unlikely that people will listen to advice. Otherwise, I would be very firm on that.
But it should just emphasize it's up to each member state to choose what way they want to go. There's no common EU legislation or competence. So it's like Andrea said, ECDC makes risk assessments, can put options, but then it's up to each member state to decide how they want to implement it. So there's no right and wrong or nothing you should do. It's up to each member state to choose. Do we have here? We have another microphone.
Thank you. What is the capacity for the testing? How many samples would be possible to test in 24 hours in Sweden today?
Okay.
I think we have high. I know we have high capacity. We have. So far in our laboratory tested close to 200 people, 170, 180, we're getting to 200. Now we're putting up the test also in other 5 or 6 places in the university laboratories starting with Gothenburg this week and Stockholm, etc. So I mean, I don't think there is a lack of testing capacity in our country. I can't answer for other countries. We are usually helping out other countries in this part of the world with the other rare diseases. So if that happen, I think we've also capacity to help out our neighboring countries.
But it's rather tens than hundreds a day with the methods you have today.
I mean, scaling it up to 7 laboratories, I would say we're close to hundreds now.
And I mean, the laboratory survey that we did, that sort of the status is mid-February, said that we, in Europe, all over Europe, we could test over 8,000 samples per week. So, and that was still not counting those countries that are still scaling up. So I think lab capacity for me would not be an issue right now.
No, I don't think so.
Yes, we have another question here.
Here, around the pillar.
Hello, thank you very much for very interesting data. And I would like to ask about healthcare-associated infections, part in this group of patients. How many is known as patients' healthcare-associated infections? And also to part, especially between staff, how many staff was infected and died?
That question I give to Josep, because I know that there were hospital outbreaks, and I know there were hospital or healthcare workers infected, and also among the dead.
Yes, in these kind of situations, as you know, there are always healthcare workers affected. So the numbers that are being dealt so far in China is 1,700. So there are particular analyses that has been done in this regard. And then also the case fatality of those cases, that is very low. So it's even lower than 2. It's less than 1. So which means that there is, even if there are cases, those cases are recovered, and there is not a major concern of that, because as I mentioned before, it is something that is expected, even if some measures are taken.
My question, I assume some of those cases also occurred before the outbreak was really not known. I mean, some of the patients were treated as normal.
I mean, we are looking right now at the information that we have is the first 6 weeks of this outbreak. So, of course, that is what we have to take into account. And among the European cases, there was only one general practitioner, who was treating 2 of the imported cases in France who got infected, but very mildly also.
So another question here, on the third row.
Thank you. I would like to shift to another field, maybe, which is the field of treatment, patient treatment. And it has been reported that convalescent serum has shown some efficacy in treatment in China. And for this reason, I'm wondering if there are any directives about how to sample convalescent serum in Europe, and how to distribute it in case it could be effective in patient treatment. So you perhaps have a contingency plan for that aspect.
I mean, regarding treatment, right now there is no how can I say, confirmed treatment, specific treatment for the disease. So all the treatments that we're talking about is symptomatic, so looking at the symptoms. However, as you say, there are actually in all parts of the world where there are cases, of course, specifically in China, trials with existing antiviral drugs and other approaches. But there is no directive yet as to which one is the one that you should pursue. So they're all in a testing stage. I know that within Europe we have a consortium that looks that can organize clinical trials. So that is right now being set up so that it can be activated. Because I mean, right now we actually don't have so many cases in Europe that we can conduct a trial.
And even though if there is no, as Andrea mentioned, a specific directive for that, there is an EU directive on substance of human origin that it's considered for those kind of situations. So even there is nothing specific for that regarding to treatment. For whatever kind of cells, blood and tissues, there are directives on how those products have to be dealt and which rules have to be followed.
But what you mentioned is the safety of these products, but that was not the question I understood. It was more using the serum as for the therapy. Yeah. So.
Could I have a follow-up question there? Because we read a week or two ago about vaccination and that British researchers were on the verge or were to find a vaccination for this. Is that something we have more information about?
No, I don't. And what I have been saying all the time is that maybe we should also, since it seems that the groups that are most vulnerable for this virus are similar to those that are vulnerable for influenza or strep pneumoniae, that is really the time now also to that these groups that where there's a recommendation to be vaccinated for influenza and strep pneumoniae, that they should get this vaccine, because right now we are still in towards the peak of the influenza season. So I think that we should also take into account to minimize the impact as much as possible.
We have another question here on row 5 over there. Sophia, I think you're the closest.
Hi. I was wondering about the reports on infections. We've seen one case in Africa, none in South America, none in Central America. Is that because they have not routines for testing, or is it because there has been no cases, or is it because they have no routines for communicating cases that they found?
I have to admit I can't give a reply regarding South America. But we have asked, as I said, we have a collaboration with the Africa CDC. So we have liaised with them, and they are actually now rolling out the testing capacity. However, there are also, especially in those countries and cities where they have direct flights to China, they are screening the incoming passengers. So that is what is in place. If there are any, whether this is sufficient to detect all the cases, I am not so sure. But that is what they are working towards right now.
I can also add, we are also having a lot of contacts with, especially the African, many African countries. And I was last week in Kinshasa, just to discuss these matters, and also to Brazzaville, to the WHO regional office. And I was positively surprised that they have a very good idea of syndrome surveillance, and they're putting in place whatever they can. It's totally right what Andrea says. There is a lack of capacity for laboratory testing, but at least I would say they would be able to detect an outbreak at this stage. Probably not single cases, but they are, and especially the regional office are putting a lot of effort into this. And also, of course, they're still struggling with the Ebola outbreak in Eastern Congo. So, I mean, in their perspective, this is probably not the top priority when it comes to surveillance, but they are experienced in that field these days.
And it's true also that some measures that were put in place, what we call preparedness measures, how you are prepared to deal with in some countries that were surrounding the Democratic Republic of Congo, where there was the outbreak of Ebola, can be used to some extent to implement preparedness plans for this disease.
Yes.
Do we have any more questions? Yes?
I was wondering, what is the capacity in Sweden of detecting an outbreak that goes under radar if someone comes in and is not detected? And how fast would that be possible?
I think that's for Johan.
Yeah.
I would say the capacities in this country for detecting outbreaks and detecting spread of diseases is high, and we have a very tight system when it comes to children's health, when it comes to communicable disease surveillance, etc. So I'm not. We haven't seen. I wouldn't say we've never seen, but we haven't seen major outbreak that we can't detect very, very rapidly in the Swedish system, because the medical intelligence system and all the cooperation between the various levels is very tight. So I would be very confident that if we have something spreading, it wouldn't go under the radar very long.
I have a question to Andrea, because you mentioned normal, so to say, winter flu that we have vaccination against. What is the difference? Can you make a comparison between the coronavirus and the normal winter flu, so to say? I don't know if it's possible yet. Maybe it's too early, but to just get a feeling.
I mean, as you say, it is too early, because I think we should wait now at least until the end of the season, when we can really make difference. But I mean, although it's not in the media, but there are thousands of Europeans that die every winter of Europe. Thousands.
Of the normal winter
Of
flu.
the normal winter
Winter
flu.
flu.
Yeah.
Yes.
So, and that is not an extent that we are seeing neither in China, actually, for this outbreak, and definitely not here, because we have so far one person that has died among the European cases, and that was a tourist from China, actually, that was already quite advanced in age.
I think one of the problems with an outbreak like this is it's something new. I mean, this is always that scares people. But the more we get to know it, as you mentioned, the less problematic it is. Of course, it starts with these serious cases, and the more cases we collect, we see that about 80% are mild cases. I mean, and we need to compare it with a lot of other problems in health, communicable diseases and non-communicable diseases, and to that respect is so far not a major problem. But of course, the problematic is that we don't yet know what is going to happen from this when it comes to spreading, even if it seems to be a little bit contained. But
I mean, that is why we're monitoring, because I mean, there's not daily, but very frequently is now new information coming out from overview of clinical cohorts and so forth, and we're always taking this into account and see whether there is a need to review our risk assessment, and whether there is any new information that we can give out. For instance, if we get more information that this is the fecal oral route is an important part that has to be taken into account, then of course also the preventive measures have to be adapted. And that is what we are currently doing. We are really having a sort of a kind of a science watch, where we look through the scientific publications and try to see whether anything in there would make us change our assessments. And that's the only thing that you can do at this stage. And until we have the firm the information on certain parameters, we can only try to do an analogy to known viruses.
And we also need to be quite proactive in communicating also, because as you know, in these kind of situations, like Johan mentioned, when there is something new, there is always these conspiracy theories that come here and there, and then try to look some hypotheses that no one has tested, no one has identified. So that's why the responsible of public health need to communicate what we know, to say what we don't know, and to say what information do we have. So we're putting that in the right way and the right time, I think prevents of some information that is not accurate and it's not even useful for the population in general.
So, do we have a last question? Otherwise, I think we are starting to run out of time. I don't see that. Then I think it's in this era of fake news, I think it's extremely valuable to have two agencies here, the ECDC and Folkhälsomyndigheten, to give us the facts. I think I at least feel a lot more informed than before. So a big thank you to you and to the audience for coming.